evening, everybody. My name is Ahmed Shawi. I'm a professor of cardiology at Ain Shams University and a board member of the IAVA Society. I'd like to welcome you to this series of webinars, this series of accredited webinars on heart failure with reduced ejection fraction. This is a 3-day series. It's today, it's next Friday, the 8th of October and the 30th of October. This is not just giving you any insights into how to treat heart failure with reduced ejection fraction. No, these are cases and the different phenotypes. We saw the guidelines, and the guidelines are talking about just managing patients with the 4 medications that have reduced mortality. No, we're going to put it into context. A patient who is diabetic, a patient who is non-diabetic, a patient with a low blood pressure, a patient with post-myocardial infarction or ischemic heart disease, a patient with CKD, and we're going to try to sequence and see how we can sequence the medications to be it more practical. I'd love to thank the board members and the chairmen and the speakers. Today, co-chairing with us is Professor Mohammed Salim, my big brother, a great friend, a consultant cardiologist at the National Heart Institute. Today, we're going to have 2 presentations. And please be interactive, because there are polls in the middle, and I would love to know what you are thinking of. Whether on your computer, click the button, or on your smartphone, just swipe or just touch it. That's very important. I would love to thank again AstraZeneca for their unrestricted educational collaboration, starting with Dr. Ahmed Maawad, Dr. Iman Sami, who were behind the idea, and also the dynamo, really, Ahmed Ramadan, Dr. Ahmed Ramadan from AstraZeneca. Thank you so much. And finally, but not lastly, I would love to thank ICOM because of their great ingenuity in presenting these webinars and making them real-like and very good. Thank you so much, all the team at ICOM. And I have to reintroduce also Professor Nabil Farag, the head of the cardiology department at Ain Shams University. Always a pleasure having Professor Nabil. It's always a great scientific benefit for us having you, Professor Nabil. Thank you all, and we will start shortly after Professor Nabil and Professor Mohammed introduce the first session.
Thank you very much, Dr. Ahmed, for the introduction. Actually, you are great, Ahmed. You are a great professor, and you do a lot of scientific activities. And actually, myself, I depend on you on a lot of activities in the department, and you do it very, very well, and you made the image of cardiology department is very good. Thank you very much, Ahmed, for this. I would like to thank AstraZeneca for inviting me to moderate this important session and these important presentations. Actually, AstraZeneca also is contributing a lot in the Department of Cardiology department at Ain Shams University, and helping the department in introducing many things to make it up to date and to help the young doctors in achieving a lot of things they couldn't achieve before. Thank you very much, and I'll be happy to be with you, Ahmed, and Dr. Mohammed Salim. I saw him also. محمد طبعا
مساء الخير نبيل.
مساء الفل حبيبي. يعني محمد مش اقول ايه يعني I love him very much, actually. I like your presentations, your
thank you very much. It's almost my pleasure and honor, Dr. Nabil.
And I leave the floor for you, Mohammed.
Thank you, Professor Nabil. It's almost my pleasure and honor to share with you this important session today, which will be conducted and presented by 2 eminent speakers. We will start by Professor Ahmed Shawi, I always enjoy his presentations, and his presentation will be about the management of HFrEF patients in patients without diabetes. And his presentation will be case-based and will be interactive. Professor Ahmed, the floor is with you.
Thank you so much. Lovely to co-chair with Professor Nabil and Professor Mohammed Selim. It's always my pleasure. And as you see from the first slide, if you see the first slide, this is EBAC accredited. So please, at the end of the session, go claim your certificate. These are points that are EBAC. I have to really thank AstraZeneca and ICOM. They did a great job for accrediting this, and this is probably the highest level of accreditation for cardiology is the EBAC accreditation. Again, these are interactive cases. This is not a one-way lecture. And we have the literature in between the polling questions. Please, please, as much as possible, use the polling questions. So let's take a look at our patient. Our patient is a 49-year-old male. He's married. He has 2 offspring living in Egypt, in Cairo, which is the capital. Of course, for anybody who is not Egyptian, this is just an example. He works in an office-based scenario. He's not diabetic, not hypertensive, smoker, smokes 1 pack of cigarettes, and which is not uncommon, but he has positive family history of myocardial infarction, but started to complain of shortness of breath of the last, for the last 10 hours, 1 week. And the history actually was quite longer. It started maybe 3 years ago. He complained of progressive shortness of breath and orthopnea. He had an ECG, and it was normal. So he did an echocardiogram, which showed that he had a cardiomyopathy. And actually, he did a coronary angiogram at the time because he was young, and a lot of physicians said probably this is of ischemic etiology, which is the commonest cause of HFrEF in all patients around the world, but it did not turn out to be that, and he was diagnosed as having a dilated idiopathic cardiomyopathy. He took medical therapy, but he has recurrent hospital admissions. He still has progressive dyspnea, sometimes orthopnea, and still now lower limb edema. And his last admission was 3 months ago. So the complaint may be shortness of breath of 10 hours, but actually, if you look at the history of present illness, which is very important, it spans over a couple of, or 2 or 3 years. His examination, which is really important, heart failure is a disease of signs and symptoms. Blood pressure is there, is fine. Heart rate is okay, regular, felt peripherally. There is bilateral lower limb edema just above the ankles, no congestion in the lungs with an elevated JVP, and the apex is shifted down and out, and there is an apical third heart sound. So comes the first question, and we know that heart failure, whether reduced, whether mildly reduced, whether preserved, is a disease of clinical diagnosis. So are these symptoms and signs that we saw, are they typical of heart failure? The signs are typical, but the symptoms are not suggestive. The symptoms are typical, but the signs are not suggestive, or both of them are not suggestive for heart failure. And this is quite important. So please, vote, and we will see the data of the polling in 15 or 20 seconds. So why is this important? I think, Professor Nabil, because it is a clinical scenario, heart failure. What do you think, Professor Nabil? Sorry, Professor Nabil, you're muted.
Sure, Ahmed. Actually, heart failure is a clinical syndrome. As you said, actually we have heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with preserved ejection fraction. And all of them share the same symptoms and signs. And symptoms and signs usually can diagnose heart failure in general.
Very importantly, yes, the symptoms and signs of heart failure are not related only to one entity, they're to all the entities. How's the polling going, ICOM? If it's nearly there, please tell me. I'm waiting just for the polling. I cannot. Okay, if yeah.
I would like to ask you, Ahmed, till the voting.
Yes.
Comes. What about patients with mildly reduced ejection fraction in the new guidelines? Should be treated like those with reduced ejection fraction, or should be put like those with preserved ejection fraction, or this is a separate entity and needs a special treatment?
A very good question, and we might go through this. But mildly reduced has part of the reduced ejection fraction symptoms and signs and management, and it also has some of the, the ununderstandable classifications and pathophysiologies of HFpEF. But now in the newer guidelines, they are mainly related to those with HFrEF, and thus this course on HFrEF really actually can also be used for treatment of HF mid-range, or what we now call mildly reduced. So I see most of the answers are actually towards A. The signs and symptoms are typical, which is very important. Let's take a look. Actually, this is from the 2016 guidelines because it showed the signs and symptoms in a very simplified clinical scenario. Breathlessness, typical. Orthopnea, elevated JVP are specific signs. Third heart sound, a laterally displaced apical impulse, and a cardiac murmur is less specific. So actually the signs and symptoms are typical and specific, and this is quite important. So clinically, this patient has heart failure. We know he has heart failure from 3 years, but let's take a look at his worsening of symptoms. And as professor, we have 3 entities. They were updated from just this year, actually, in not only the European guidelines, but the consensus on the diagnosis. We have the reduced ejection fraction, which are considered those with symptoms and signs of heart failure with an ejection fraction at 40 or below. Mid-range, which is now called mildly reduced, with symptoms and signs. Again, look at symptoms and signs are essential for diagnosis of heart failure, and with an ejection fraction of 41 to 49. And then we have the HFpEF, or the preserved ejection fraction, and those who have symptoms and signs, again, symptoms and signs with an ejection fraction of 50 or above, and there is objective evidence of structural heart disease. So let's take another question. This is your patient. He's coming with, let's say, deterioration of the cause. So what would you do for an investigation for this patient? An ECG, an echocardiogram, do a full lab panel of labs, chest X-ray. Let's take a look at what you probably might do. I would like to see the importance and the ones you think of first. Professor Mohammed Selim, I think you're with us, and probably
yes,
we do a lot of these investigations, I think.
Yeah, each one of them carries important tool for investigations in heart failure with reduced ejection fraction. ECG can give us an idea about the rhythm of the patient, the chamber enlargement, the presence or absence of any ischemic changes, which can lead to the etiology of the heart failure with reduced ejection fraction. Of course, the echo is for investigation to give an important idea about the ejection fraction, the dimensions, the presence of mitral regurg, pulmonary output pressure, and so on. Also, the blood chemistry is very important regarding especially the kidney functions, the electrolytes, the thyroid function. Each one of them will give us a very important piece of information which has a very important therapeutic implications. Also, chest X-ray about the degree of pulmonary venous congestion, the cardiac size, but still, chest X-ray can give us some important information. Well, we will see what will be the pull, and I think it's an easy question.
Yeah, I think it's an easy question. We're waiting for the answers to come in. And actually, it's very important that like you said, we are not only diagnosing heart failure with these investigations, we're guiding the way we treat, and we are looking for confounding factors that are manageable. And actually, you know, these are very important investigations to be used. Professor Nabil, would you like to comment further until we get the results of the poll?
Yes, sure. Number one, if I would put in priority, the one echocardiography comes number one because it's already put in the guidelines as the classification of heart failure depends on the ejection fraction measured by echocardiography. So if we have all of them have the same symptoms and signs, but the differentiating tool between heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with preserved ejection fraction is the echocardiogram. So echocardiogram is the cornerstone in differentiating different forms of heart failure. ECG is very important, as Dr. Muhammad said, and ECG for diagnose, for example, for diagnosis of the etiology of heart failure, for ischemic heart disease, can diagnose ischemic heart disease. Even ECG can help in diagnosis of patient presenting with heart failure with preserved ejection fraction due to cardiac amyloidosis, and this is a new interesting, not a new disease, but it is recently discussed a lot because if we have a low voltage ECG and an echocardiograph showing left ventricular hypertrophy, this what we call low voltage versus high LVH is helping diagnose of cardiac amyloidosis. Blood chemistry is mandatory because we have to check for the renal function, for the electrolytes, which guides the treatment in heart failure. With other tests like looking for risk factors for ischemic heart disease, we have to check for lipid profile. We have to check for diabetes. We have to check for thyroid function. We have to check for liver function. All of these are what we call routine tests that should be done. CBC to check for hemoglobin. Sometimes anemia may be a cause of heart failure. And as Dr. Selim said, chest X-ray also. This chest X-ray is good, but this is not a cornerstone. I think ECG, echocardiography, blood chemistry are the main, and the chest X-ray comes if you want to check for pulmonary congestions and things like this.
Guys, you're getting a masterclass from two of the best professors you can get, Professor Nabil and Professor Mohammed Selim. Thank you. And this is the diagnostic algorithm for heart failure, and everybody really went through this, that we need a lot of echo is very important. Of course, if you have doubts, the cardiac natriuretic peptides like the N-terminal or pro-BNP or BNP are important. And of course, looking at others like the blood chemistry are important. As you can see, we have to have an echo, we have to have a blood chemistry, and very importantly right now is assessment of the total airbagging capacity or total TSAT, which is important because, as we've seen, ferric carboxymol tools and treatment of anemia is quite important. ECG is important, and like Professor Nabil said, a chest X-ray is something which is extra. It is not mandatory. It's especially in those that we think that there might be another problem like pulmonary disease, and this is perfect. So our patient did his labs. As you can see, they're all fine. There was nothing abnormal. The cutoff points for the ALT and AST were 40, so these are within normal. And everything seems fine, a little hyponatremia, if you want to say that. You see the ECG, it's more towards left bundle, and we can discuss this more and more because, of course, those with a white complex might benefit from certain interventions like a CRT. And of course, the chest X-ray, you can see there is cardiomegaly, and this is quite evident in those with a dilated heart. The echocardiogram, as you can see from these videos, that there is, dilatation of the left ventricle, poor function, and I don't think the function really surpasses 30 something percent, with moderately severe tricuspid regurgitation and dilated dimensions. And as we know, the patient has history that his coronaries were okay, so there was no actually, coronary artery disease, and there's also moderate mitral regurg. What is next? Actually, this patient has been treated in so many medications. He was treated
Dr.
as
Ahmed, I'm
yes.
very sorry. I'm very sorry. Can I interrupt you for 1 minute?
Please go
just an announcement for the audience. In order to be able to vote, they should click first on the vote button before they are able to vote. Okay. Very important. Click first on the vote button. Then they will go for a vote. Thank you. Go on. Thank you.
Thank you, Dr. Mohammed. Thank you. That's a very important note. Yes, so we can have more and more interaction. It's important. What I'm writing here are the patient was transferred through so many physicians, some internal medicine physicians, some general practitioners, younger cardiologists, and the four first combination of medications were actually written for the patient. And actually, I would like to understand, if you have a heart failure with reduced ejection fraction like our patient, which of these medications is most suited for a patient who has heart failure with reduced ejection fraction? Is it A, enalapril atenolol, B, ramipril atenolol, C, telmisartan carvedilol, D, captopril carvedilol? We know RAS blockade is important, especially ACE inhibitors, some ARBs, and of course in the newer guidelines, the ARNI. And not all beta blockers are to be used. Beta blockers until the 2000s were actually contraindicated. I think you remember this, Professor Nabil, that
sure, Ahmed, yes.
If you write a beta blocker in heart failure with reduced ejection fraction, it wouldn't be a nice day for the round. Yeah. So let's take a quick poll. I just want to see if anybody really disagrees with some of the medications, because this is quite important to take into consideration. Don't take into consideration the anti-ischemic. This is a misspelled. He is not ischemic. I'm talking about the treatment for the HFrEF. RAS blockade and beta blocker, which ones would you choose? I think as we go on, I think we can go faster with the polling, and I think everybody's going to be better to be. And I'm not writing things out of my head. These are actual medications that the patient was prescribed with. So this is quite important.
This is a real patient, Ahmed. I see.
Yes.
A real one. Yes.
Yes. Okay. I see we have a split, and this is important. We have a split between B's and C's as the biggest amount of prescriptions or votes going so far. This is quite important. I'll tell you why. Because when we write medications, we should write the evidence-based medications, a phrase which is very important. The updates for heart failure have been many, and in 2021, in early January, there was an update from the United States, from the ACC, and actually they were talking about, of course, adding, first of all, a RAS blockade, the beta blocker, and then adding other medications accordingly to the patient. If the patient has a glomerular filtration rate above 30 and his HFrEF is still symptomatic, we can add an aldosterone antagonist, SGLT2s, and we'll get to that. Of course, if you have volume overload, of course, a diuretic is quite important. And of course, up titrating to an ARNI is preferred. If the patient is Black or of Black ancestry, hydralazine or isosorbide dinitrate. Well, the Europeans also agreed on the 4 pillars that they call the ACE, ARNI, beta blockers, MRAs, and SGLT2s. And these are all class 1 indications because these 4 medications have been shown to reduce cardiovascular death. These are the only medications, tablets, that have shown to reduce cardiovascular death. But actually, first of all, the only beta blockers that can be given are carvedilol, bisoprolol, metoprolol, and nebivolol. If you're in Europe, nebivolol has no FDA indication for HFrEF, even though it has data. If you have an ARB, which have been relegated in the newest of guidelines, there are only 3 which can be used. They are candesartan, valsartan, and losartan. Telmisartan is not a medication that can be given in HFrEF. It has no data to support this. Atenolol as a beta blocker is a very potent beta blocker when it comes to hypertension, but has no data in HFrEF. So actually, it was captopril and carvedilol, which were actually the medications that were correctly given to the patient. The other 3 combinations actually are not guideline or evidence-based medicine. In addition, he was given eplerenol, which is a mineralocorticoid antagonist, and it really doesn't have the side effects of spironolactone as like gynecomastia. But on the medications and up-titrated, you can see Ramipil was given in 10 milligrams, carvedilol 12.5, eplerenol. There is still shortness of breath. You can see the blood pressure is 100/60, but the heart rate is over 80. So again, another vote, please. What would you do? Would you add diltiazem, which is a calcium antagonist to control the heart rate, add digitalis to control the heart rate, change the beta blocker from carvedilol to metoprolol or bisoprolol, or would you add ivabradine for this patient? And I think Professor Nabil, Professor Mohammed, we see a lot of patients of HFrEF, their heart rate is not controlled, a big percentage at least. Would you agree?
Yes, very frequently, yes.
And thus, this heart rate uncontrolled is actually a very important, it's not deleterious like in the ICU, but of course it does carry a poor prognosis for symptomatology and hospitalization. Do you have another choice out of the 4 that you would, other than the 4, sorry, that would you add, Professor Nabil, Professor Mohammed? Would you like to?
Actually, but I would like to highlight some important things that in the guidelines they mentioned that beta blockers and up titration of beta blockers to the maximum dose based on the guidelines or the maximum tolerated dose by the patients. And if we look at the blood pressure of this patient is 100/60 and it's a borderline blood pressure, I don't think we want to go lower than this in spite of having heart failure with reduced ejection fraction. So I don't think that up titration of carvedilol will be a good choice. That can be added, but I don't think this is a good choice. If we are talking about the use of calcium channel blocker in a patient with heart failure with reduced ejection fraction, this is a contraindicated. If digitalis comes at the bottom of the algorithm of treating heart failure with reduced ejection fraction, and digitalis may be good for patients with heart failure and atrial fibrillation. Adding another beta blocker to the medication, I don't think this is good because we don't recommend adding 2 drugs of the same class. It is not recommended to do to add, for example, ACE, even ACE with ARBs are not recommended, and so any beta blocker with another beta blockers are not recommended. Here, ivabradine comes طبعا in the 3rd row of algorithm in treating heart failure with reduced ejection fraction, especially if the heart rate is still above 70 beats per minute and this patient having a heartbeat of 80 beats per minute. I don't like to guide the audience to the answer, but This is just some explanations of what is seeing, and I think waiting for the.
Actually, Professor Nabil, they answered before you got to D, and actually 90% said add ivabradine, and this is excellent. And actually, nobody added digitalis, which was being used a lot. It's not so wrong, but as you said, lovely, that digitalis goes at the lower end of the pole, and it's very good when the patient has atrial fibrillation. It's not so good when sinus. And this has been the algorithm since 2013, actually, that if a patient is in sinus rhythm with a heart rate above 70, yes, ivabradine has been shown to reduce heart failure hospitalization and mortality as seen, cardiovascular deaths as seen in the HFrEF trial. So actually, great. And thank you so much. Again, that's what I'm saying. You guys are having a masterclass with Professor Nabil and Professor Mohammed Selim. It's lovely to have these excellent moderators with us. But the patient took the ivabradine, but still the patient has, shortness of breath, admitted again, has recurrent palpitations. Actually, premature ventricular beats were significant after Holter was done. Non-sustained runs of ventricular tachycardia, but very, very short. I'm not talking about an ICD indication here. But what would you do for the medical treatment? Ramipril is 10 milligrams. Would you increase the dose of Ramipril? Would you stop eplerenone? Would you replace Ramipril with an ARB, which is evidence-based, like valsartan, losartan, candesartan? Or can we replace Ramipril with an ARNI, which is the angiotensin receptor neprilysin inhibitor, sacubitril valsartan? Again, Dr. Mohammed Selim, you see a lot of patients getting the best of medical therapy or guideline medication, but they still do not do 100% as we expect them. What is your comment about this?
Very interesting case. And now we have a patient receiving guideline-directed medical therapy, including ACE, beta blocker, MRA, and ivabradine, just to control his heart rate. And still the patient is symptomatic. He started to develop high serum potassium, a little bit, 5.1 now, with symptomatic frequent ectasis or premature ventricular contraction, and even though also non-sustained runs of VT, I think if I will go increase the dose of Ramipril, will not be a suitable option, of course, due to potassium is high. Stop eplerenone, I will leave it for the audience. Replace Ramipril with an ARB will not add any benefit and may also increasing the hyperkalemia. Replacing Ramipril with an ARNI may be an option, but however, also the potassium, high potassium is a concern. So I will leave it for the audience, but I try to explain the main problem now we are facing with the patient, starting of rise of the serum potassium together with non-sustained VT.
Okay, thank you so much for your excellent comments. Ahmed, I would like to stress on or to highlight yourself about the potassium level. At which level we have to be, we have to reduce the dose of some medications, and at what level we have to stop the medications that cause elevation of. And I think and which one should be stopped first? We have the ACE inhibitors and ARBs, and we have the MRA, and we have the ARNI. All of them can lead to increase in the potassium level. Myself, it's a 5.1 is still not a contraindication, or even to lower the dose of any of these or to stop any of these drugs. So stopping eplerenone will not be good, because still we are in the range, I think, which is accepted for us. Also, increasing the dose of Ramipril is not a good option. Replacing Ramipril with an ARB is not a good option, because it's not recommended by the guidelines as a patient still symptomatic. And in the guidelines, we have a very clear quotation and very clear statements about persistence of symptoms in spite of, as Dr. Muhammad Salim said, the guideline-directed medical therapy. And I think this would change even in the future. The ACC guidelines make ARNI comes first, but still, if we have symptoms with ACE inhibitors, maybe ARNI would be a good choice in a such patient in spite of being potassium 5.1.
Very good comments, very important, and thank you. This is a highlight that we should really touch upon. Hyperkalemia in most trials was either 5.5 or more potassium or 6. And actually, let's talk partly about which is the most serious to stop if you have a hyperkalemia. It's probably the MRAs, the mineralocorticoid antagonist. And if the patient is still symptomatic, since the 2016 guidelines, and here in the 2021, sacubitril valsartan, or the ARNI, is given as a replacement for an ACE inhibitor to reduce further the risk of heart failure, hospitalization, and death. And this could be used as initiation and de novo, as Professor Nabil said, in certain patients because of the safety that came out of PIONEER. And we know in heart failure with reduced ejection fraction, we have stimulation of the sympathetic nervous system, which is counter-regulated by the beta blockers, the RAS system, which is counter-regulated by the RAS inhibitors, but actually the natriuretic peptide system, which is good, but degraded by neprilysin. And we get this neprilysin inhibitor, the NI in the ARNI, which increases the natriuretic peptides, which is good. And through paradigm heart failure in 2014, we saw a significant reduction in heart failure hospitalization and cardiovascular death as compared to enalapril by sacubitril valsartan. Also, in all the endpoints taken by themselves, there was reduction, which was significant. And actually, I would like to say also that it also reduced the risk of hyperkalemia as compared to enalapril, and this was part of the paradigm. So if we're going to replace the patient with sacubitril valsartan, which is the ARNI, it's one of a kind, so we don't have any other medication except Sac-VAR, what would you do? And let's make the polls a little bit quicker because I don't want to go over my time. Would you stop ramipril and start sacubitril valsartan immediately? Stop ramipril and start sacubitril valsartan the next day, or start after 36 hours or after 1 week? I would like to see how our colleagues are managing these switching. So I think 10 seconds. I don't think this requires a lot of time because I don't want to go over my time. And okay.
Also, Ahmed, I would like you to highlight why we shouldn't start immediately sacubitril valsartan after ramipril. And since this is a very important point, and there is a great risk of adding this drug immediately after ramipril.
And I see 100% of those who voted go for C. It's after 36 hours. Actually, it was 24 to 36 hours in paradigm heart failure. And according to the dose, we can use an equivalent dose of sacubitril valsartan. And this is to avoid allergy or angioedema. This is important. However, if the patient is taking valsartan or candesartan, an ARB, the sacubitril valsartan can be used at the second dose. So this is something to take into consideration. If it's an ACE, no, you have to wait for 24, better 36 hours. Again, another question, does our patient with the different things that we saw with the Holter, the 8,000 plus PVCs, non-sustained short runs of ventricular tachycardia, would he require an ICD insertion? Yes or no? This is another question, which is very quick again.
And he's ischemic as well, Ahmed.
He's not ischemic. He's not ischemic.
He's not ischemic.
He's not ischemic.
Yes.
Very important question to Professor Nabil.
Yeah. Can you remind us, Professor Ahmed, by his ejection fraction?
It was around 30%.
Yes.
His ejection fraction, which is the cutoff point, yes, for an ICD. He had a lot of premature ventricular contractions, short runs of ventricular tachycardia on Holter monitoring because he was symptomatic for palpitations. So a quick vote because this is quite important. And Professor Nabil asked a very important question, presence of ischemia or non-ischemia. And again, this was a 50-50. I like the vote. I love these votes. Well, actually, an ICD is important in those with an ejection fraction below 30% or 35%, of course, it's despite 3 months of optimal medical therapy. Actually, this patient, when he took sacubitril valsartan, his PVCs were reduced, and there is, since 2016, a reduction of premature ventricular contractions and malignant ventricular arrhythmias by beta blockers, MRAs, and sacubitril valsartan as per guidelines since 2016. If the patient has ischemic etiology, and this was the question Professor Nabil was asking, it's a class 1. If it's non-ischemic, it's not a class 1 anymore like it was in 2016, it's a class 2A. So again, this patient has to have an ejection fraction below 35 or 35 or below, despite, and having, of course, an increased risk of sudden death, despite more than 3 months of optimal medical therapy. And actually, this is a class 2 for our patient, and it's not that important. So our patient is taking sacubitril valsartan, carvedilol, eplerenone, ivabradine. I think these are the best. Actually, there was improvement of the PVCs as we've shown, and it was up titrated to the maximum dose of sacubitril valsartan. Still a little bit dyspneic, still not able to do everything he would like to do in his life. What would you do to this patient? This is an important question. Would you do nothing? Just reassure? I'm not saying nothing, of course, that you don't do anything. Maybe add a little bit of diuresis, add an SGLT2 inhibitor, or go, like Professor Nabil was just pointing out in one of the questions, that digitalis is there, of course, if the patient is symptomatic in certain indications. Professor Nabil, Professor Mohammed, I think we see some patients, even though they take the best of medical therapy, they still...
Yes.
I'm expecting the answer, the correct answer to be 100% in this question, because the answer is very clear, Ahmed.
Okay, I'm going close to the monitor. Excuse me, looking. Okay, but we got 75% for C and adding an SGLT2, and actually, which is not wrong if the patient is a little bit congested, some adding a diuretic. Of course, this is, of course, if the patient is congested. Again, lovely interaction from everybody. Well, let's look at the guidelines. The ACC, they put that SGLT2 inhibitors are a class 1 indication for all patients with HFrEF if the patient is symptomatic. And this is what is called a stage C, a symptomatic HFrEF patient. And the cutoff point for SGLT2s if the patient doesn't have a contraindication. The contraindication is having a low GFR, below 20 or 30, or type 1 diabetes, because of course we still don't have enough safety data on SGLT2s in type 1 diabetes. But our patient is non-diabetic. This is an important question. Is it safe adding an anti-diabetic? And I remind you, these medications are anti-diabetic. In non-diabetics, this is the question, yes or no. I think Professor Nabil, Professor Mohammed, you see this a lot of questions from some of the patients and some doctors actually asking this question about the safety of these medications in non-diabetics.
Yes, Professor Ahmed, it's very important to rehearse that or re-emphasize that the mechanism of action of SGLT2 inhibitors is insulin independent. This is very important. So there is almost no risk for hypoglycemia. They are, by inhibiting the enzyme of sodium glucose co-transporter in the proximal convoluted tubule, they will bring back the renal threshold of glucosuria to the normal range. So as long as there is no hyperglycemia, there will not be any more effect to induce hypoglycemia of these agents. So the simple answer of this important question will be they are completely safe, or almost they are safe and tolerable in non-diabetic patients. And also the new guidelines stressed upon by the 4 weeks of presentation of patients with heart failure, we have to commence or start the 4 pillars, including the RAS inhibitors, the beta blockers, the MRA, and the SGLT2 inhibitors.
I'd like to tell you guys that 100% said yes, they're safe. I think we've done this. And this was the rationale before doing DAPA heart failure, that we have similar pathophysiological features between diabetes and heart failure. And as you said, the cardiovascular benefits of SGLT2 were largely independent of the glucose levels, and the mechanistic effects do work in patients with or without diabetes. And if you look at DAPA heart failure, which was the first and the biggest study on HFrEF using dapagliflozin, most of the patients were non-diabetic. This is quite important. More than 57% or 58% were non-diabetic. And all of them, whether diabetic or non-diabetic, and took 10 milligrams of dapagliflozin, improved in mortality, improved in heart failure hospitalization, improved in symptomatology. Even those that were taking an ARNI or no ARNI, they showed an improvement, which was also a very significant reduction in mortality and also in heart failure hospitalization. And it was regardless of any other comorbid factors. I would like also to tell you that those who were non-diabetic in DAPA heart failure, who were given dapagliflozin, the possibility that these patients developed diabetes over the years, and this was just published a couple of weeks ago, was reduced. Yani, the patients who were non-diabetic and received dapagliflozin, the possibility that they became diabetic was reduced significantly. Also, if you look at the safety, whether in diabetics or non-diabetics, the safety is incredibly high. Again, this was comparing it to a placebo. It was not comparing it to a different molecule. It was to compare to a placebo. There was a significant improvement in outcomes with a high safety margin. I thank you all for interacting. I thank Professor Nabil, Professor Mohammed Salim, and I would like to just take home messages that heart failure must be backed up with evidence, and we're talking about HFrEF. Optimal dosing and optimal medications are very important. A stepwise approach is important. We don't like to rush all medications all at the same time, but of course, according to the patient presentation, and we will discuss this more and more in the coming cases. Sacubitril/valsartan has been shown that it is superior than ACE inhibitors in reduction of hospitalization and death, but regardless, the patient is diabetic, non-diabetic, has different medications, SGLT2 inhibitors have the highest reduction in heart failure hospitalization, and dapagliflozin has reduced cardiovascular death in patients with HFrEF. Thank you so much, and I hope you enjoyed the case.
Thank you very much, Ahmed. Actually, this is a great case and a real practical case we see in our daily practice. And you covered everything about this case in a nice way, questions and answers, and this help me and help the audience to have the correct explanation why we use such medications in the patients with heart failure with reduced ejection fraction.
It's your input and Professor Mohammed Salim's input that made it great, and I'm waiting.
Thank you so much, Professor.
I'm waiting for Professor Tamer's excellent presentation to later.
My pleasure. My pleasure to introduce Tamer. Tamer is a great friend, one of the member of IAVA, and he's going to present the management of heart failure in diabetic patients. Dr. Ahmed in non-diabetic patients and Dr. Tamer in diabetic patients.
مساء الخير دكتور نبيل، مساء الخير المجموعين. يا ترى صوتي مسموع؟ الصوت واصل؟
الصوت واضح يا تامر، اتفضل.
طب تمام. مساء الخير جميعا، شكرا لأستا على رعايتها هذا اللينك الجميل. I will proceed for management of heart failure in a diabetic patient. This is our agenda today, and we will start with our case. Mr. MP is 62 years old male, married, born and living in Cairo. He has a consulting job. He has a type 2 diabetes for 7 years. He smokes 1 pack of cigarettes per day for the past 20 years. Complain of shortness of breath of 24 hours duration. This is a history of present illness. The condition started 4 years ago when the patient complained of typical chest pain. He had stress ECG, which was positive. Go for coronary angiography and put 3 stents. Patient was kept on medical treatment to which he was complained. However, now he is presenting because of progressive dyspnea, osopnia, and the lower limb edema. On examination, blood pressure was 100/70, heart rate 88, regular and felt well peripherally. There is a bilateral bedding lower limb edema up to the knees. Lung auscultations showed bilateral basal rales. There is elevated jugular venous pressure. The apex is felt in 6 intercostal space at the anterior axillary line. We hear the apical SS3 and the systolic member. The first question, what do the symptoms and signs suggest? Symptoms and signs both are typical for heart failure. Signs are typical, but symptoms are not suggestive for heart failure. Symptoms are typical, but signs are not suggestive of heart failure. Both signs and symptoms are not suggestive of heart failure. Let's go for 40. وانا مش باين قدامي اي حاجه للفوتنج. Okay. What about the symptoms and signs of heart failure? The symptoms فيها نوعين. يا اما more typical يا اما less typical. المور typical the presence of breathlessness, الاسopnia, الparoxysmal nocturnal dyspnea, reduced exercise tolerance, the fatigue or tiredness or increased time to recover after exercise, and ankle swelling. This typical are nocturnal dyspnea, nocturnal cough, wheezing, bloated feeling and loss of appetite, confusion, especially in the elderly, depression, palpitations, dizziness, syncope, and pentopy. The signs, there are more specific signs for heart failure, like elevated jugular venous pressure, hepatojagular reflux, third heart sound, with or without caliprism, laterally displaced apical impulse, and less specific about the weight, there is 3 issues. Weight gain more than 2 kilograms per week, weight loss in advanced heart failure, or in tissue wasting with cachexia. Hearing of cardiac murmur, presence of peripheral edema, whether at ankle, sacral, or scrotal, presence of pulmonary crepitations, reduced air entry and dullness to percussion at lung pieces due to pleural effusion, presence of tachycardia or irregular pulse, tachypnea or kinestokes aspiration, hepatomegaly or ascites, cold extremities, oliguria, and the nervous pressures, or are less specific signs. According to the ejection fraction, we classified the heart failure into 3 categories. Patient with ejection fraction less than 40%, this is a HFrEF patient. Patient with ejection fraction with 40 to 49, this is with mildly reduced now or mid-range previously, and patient with ejection fraction 50% or more, these are HFpEF patients. The second question, what would your investigation include? An ECG, an echocardiogram, blood chemistry, chest X-ray, or all of above?
Again, very important to reiterate that these questions are very important. Guys, please vote. It's important that at the end of the day, you know what to do. Sorry, Professor Tamer, for interrupting.
Yes, okay, I am with you, Ahmed. I am with you for answer. Let's go to know the answer. This is the algorithm for the diagnosis of heart failure. First, you should assess the heart failure probability through, number 1, the clinical history. If there is a history of coronary artery disease, like myocardial infarction or history of revascularization, history of hypertension, exposure to cardiotoxic drugs or radiation, use of diuretics, presence of insomnia or paroxysmal nocturnal dyspnea. Second, the physical examination. Auscultation of RELs, bilateral ankle edema, heart murmur, jugular venous distension, laterally displaced or broadened apical beat, and ECG for any abnormality. If all of these are absent, the heart failure diagnosis is unlikely. If one or more, you can check natriuretic peptide. But remember that the routine assessment of natriuretic peptide in cases of heart failure is not advisable. If you use natriuretic peptide, NT-proBNP more than 125, BNP more than 35, you can go for echocardiography, and you can go directly without it for echocardiography. If you confirm the diagnosis, you can search for etiology and start appropriate treatment. Here is the guidelines recommend the investigation. Number one is transthoracic echo. Is used for assessment of myocardial structure and function in patients suspected to have heart failure in order to establish a diagnosis and classify the patient with HFrEF, MR, or PEF. Secondly, we go for diagnostic tests for diagnosis of newly diagnosed patient in order to establish suitability for particular therapies, to detect reversible or treatable causes of heart failure, and to detect comorbidities interfering with heart failure. You can go with hemoglobin, white blood cells, sodium, potassium, urea, and creatinine with estimated GFR, liver function tests, glucose and hemoglobin A1C, lipid profile, TSH, ferritin, and markers of anemia, natriuretic peptide. Third, we can go for 12-lead ECG, recommended for all patients with heart failure, to determine the heart rhythm, heart rate, the QRS morphology and duration, and detect other relevant abnormalities, the information needed to plan and monitor the treatment. And last, the chest X-ray is recommended for all patients. The importance here is to detect or exclude alternative pulmonary or other diseases which may contribute to dyspnea. It may also identify pulmonary congestion or edema and is more useful in patients with suspected heart failure in the acute setting. Remember that X-ray is class 1C. This is the laboratory data of the patient. Serum creatinine 0.8, potassium 4.2, sodium 137, hemoglobin 14.5, total leukocytic count 7,000, platelets 280,000, PTT 35, INR 1, AST and LT was normal 20 and 90. This is the ECG of the patient. You can take a look for the ECG, for X-ray, and for the movie of echo, and make a concept of the diagnosis of type of heart failure. Then we discuss the next step. As we see this left bundle branch block. And this is the chest X-ray of the patient. Lung congestion is marked. And this is the movie of the echocardiography, apical fourth chamber, which show hypokinesia and reduction in the ejection fraction. So what about the treatment measures? To go with enalapril with atenolol, rabapril with atenolol, telmisartan with carvedilol, captopril with carvedilol, or any of the above combination. نبيل رايح حضرتك تبتدي ميوت.
As Dr. Ahmed said before, that definitely ACE or ARBs and beta blockers are the cornerstone in the management of patients with heart failure. But not all ACE and not all ARBs are approved for the management of heart failure, as well as not all beta blockers are approved for heart failure. For example, telmisartan is not approved for the management of heart failure as ARB. Atenolol is not recommended. Beta blocker also is not approved for use of in heart failure patients. That's why we have to use the drugs that are approved to be used in heart failure, whether ACE, ARBs, or beta blockers.
As Professor Ahmed Shawi told us that not all ACE, not all ARBs, not all beta blockers can be working the same in case of heart failure. So we'll go to know what about the 2021 update and the consensus decision pathway for optimizing of heart failure treatment, the answers for 10 pivotal issues in HFrEF. This is had been shown with Dr. Ahmed. Remember that when we add aldosterone antagonist, we should have one of three. First is estimated GFR 30 or more. Second, the creatinine, if male 2.5 or less, if female 2 or less, potassium less than 5. And patient with good estimated GFR over 30, you can add SGLT2 inhibitors. Patient have overload volume, you can add diuretics. Like patients symptomatic despite full treatments, we can establish the hydralazine plus isosorbate dinitrate. Heart rate in rest after full dose of beta blocker is still over 70, you can add ivabradine. What about the 2021 ASC guidelines for management of heart failure? This is a very important figure. It summarizes the story. The 4 corners or the 4 pillars should be given for all patients to reduce the mortality are ACE or ARNI, beta blocker, MRA, and SGLT2 inhibitors. Then we go for selected patients to reduce heart failure hospitalization and mortality. First of all, if there is a volume overload over diuretics. Then this is a sinusism or AF. Sinusism, what about the left bundle branch block? As our patient, if we have left bundle branch block more than 150, from 130 to 149, or non-left bundle branch block more than 150, to keep in mind that patient may need for CRT later on. Second, if the patient is in atrial fibrillation, 2 issues are important. Anticoagulation is a must, and maybe the use of digoxin, even the level of evidence is low, but it is an option. Second, the third issue, is it an ischemic etiology or non-ischemic etiology? Our patient is already ischemic. So if have a coronary heart disease, it should be managed well, either by medications or by revascularization. If the patient has an iron deficiency, treatment definitely is ferric carboxymaltose. If the patient has a concomitant disease leading to heart failure, like aortic stenosis or mitral regurg, should be managed probably. If the heart rate is over 70, despite maximum tolerated dose of beta blocker, we can add ivabradine. In black race who are resistant to treatment, we can use hydralazine plus isosorbate dinitrate. If patient is intolerant to ACE inhibitor or ARNI, we can use ARB. So this is the pillars: ACE inhibitor, beta blocker, MRA, dapagliflozin. All of these 4 are class 1A. The sacubitril valsartan is class 1B as a replacement for ACE inhibitor. And this is the algorithm. Remember that you should start with ACE inhibitor and beta blocker. And very important to know, you should go with up titration to the maximum tolerated evidence-based doses. If the patient is still symptomatic with ejection fraction was less than 35, you can add MRA, and again, go with MRA up to maximum tolerated dose according to the evidence. And if it's still symptomatic, we have one of 3 options. If a patient able to tolerate ACE inhibitor ARP, we can replace with ARNI. If the patient with QRS duration more than 130, we evaluate the need for CRT. If the sinus rates in sinusism and heart rate more than 70, we can go with ivabradine, all may working together. Then if the patient, if it's still resistant, we can consider digoxin, hydralazine, and isosorbate dinitrate, left ventricular assist device, or heart transplantation. The next question, do we require diuretics in our case?
Very important question, because I think these are the most used medications in heart failure with reduced ejection fraction.
برضه احمد انا ما يكون في اجابه يعني remember that in the diuretic once ان هي achieve euvolemia, the first drug to reduce the dose or stop, لانه don't continue on high dose or multiple doses of diuretics, even the patient is euvolemic, you will not get a benefit, you will get the side effects. Okay, go for dehydration, electrolyte disturbance, and so on. Once patient is euvolemic and no symptoms of volume overload or congestion.
And it's very clear, Tamer, very clear to know for the audience to know that diuretics are mainly for symptom relief, has nothing to do with prognosis. Diuretics has a lot of side effects, and some of them are serious side effects like hypokalemia that may terminate the life of the patient. That's why, as you said, once the role of diuretics finishes, it's very good to reduce the dose, or even to take to get rid of this drug once a patient is euvolemic. And nowadays we can use some drugs which are very important drugs that has a very good prognosis in heart failure and a diuretic effect as well.
Yes. So the guidelines tell us that diuretics are recommended in order to improve symptoms and exercise capacity in patients with signs and symptoms of congestive heart failure. The next question. After 1 week, patient, yes, was an enalapril and carvedilol 12.5 turizumab 10 milligram, and patient started to experience repeated attacks of dry cough and no evidence of congestion or infection. So what is the next? To change carvedilol to verapamil, to add digitalis, to substitute the enalapril with an ARP, or to increase the dose of turizumab. I exclude more congestion, I exclude presence of infection. Dr. Ahmed, رأي حضرتك إيه؟
I can see that most of the voters are going for C, go with the enalapril substitution with an ARB, and quite a little amount of people are going with increase the dose of the diuretic. Very good question, because yes, we have to, as you said, look for any other causes of cough, like congestion or infection, because this might be the cause, before really thinking that this might be an ACE intolerance.
دكتور نبيل، رأي حضرتك الانسيدنس of dry cough with ACE inhibitors in practice, actually?
I think it is, you know, I was sharing with Dr. Ahmed Shawqi about the one of the side effects of ACE inhibitors is dry irritative cough. In real life, we see a lot of these patients, but as you said, we have first to exclude congestions in such patients, because it's a common cause of dry irritative cough, especially by night. And if we exclude this and the patient still taking ACE inhibitors, so the second step is to look at this, and we have to change and to replace this drug with another one which has no such side effects, and definitely either ARB or طبعا sacubitril valsartan would be a replacement for ACE in such side effects.
Okay. So what the role of ARBs in heart failure? And ARB is recommended to reduce the risk of heart failure hospitalization and the cardiovascular death in symptomatic patients unable to tolerate an ACE inhibitor, and patient should be also receive beta blocker and MRE. Which ARB do you recommend to use? Irbesartan, olmesartan, eprosartan, or candesartan in our patient?
That's important.
Yes.
Evidence-based, we want to know which are the evidence-based ARBs. Yeah, very good question.
And I want to remind you about the approved ARBs in the management of heart failure. Always remember this.
There are 3 are allowed to use. One of them are present in the choices. let's go to know this is the ARPs allowed to be used in HFrEF: candesartan, valsartan, and losartan. So the evidence is coming for some drug like candesartan from the CHARM trial, which used the candesartan in heart failure assessment of reduction in mortality and morbidity. And the use of candesartan in heart failure patients show a significant reduction in the incidence of non-fatal myocardial infarction. Then the question after that, patient started after 3 weeks to become dyspneic, and on examination, we find a diffuse bronchi all over the chest with no evidence of congestion. What is the next? To change carvedilol to verapamil, to change carvedilol to diltiazem, to add an MRA, or to change carvedilol to another selective beta blocker.
This is quite a difficult question. I would have thought that this was been an infection or congestion, but you said there is no congestion and
No congestion.
Okay,
and diffuse bronchi all over the chest.
Okay.
And this is a case of heart failure with reduced ejection fraction.
Yes.
Yep.
Also, it's very important for the audience to know the cardioselectivity of the beta blocker. It's very important to know which beta blocker is more cardioselective than the other, and this is very, very important.
As Ahmed mentioned, we should know that not all ACEs, not all ARPs, not beta blockers are working in the same way, and sometimes a drug is recommended and working well, but some side effects had occurred, so we can't change. So remember that carvedilol is a non-selective beta blocker. Even it has an antioxidant effect, which is good for the endothelial function, but it is non-selective, and some patients are reactively has a bronchospasm due to use of non-selective beta blockers. So we will go to a selective beta blocker like metoprolol CR or XL, which is proved in the MERIT heart failure. This is the large study of beta blockade in heart failure. It was a double-blind, placebo-controlled survival study with use of metoprolol in form of CR or XL in patients with HFrEF with ejection fraction less than 40% and symptomatic with NIHA function class 2 to 4. It shows overall that there is a reduction in the mortality about 49%, which is due to the worsening of heart failure. The next question, now the patient was on metoprolol 100 milligram, candesartan 8 milligram. Patient after 3 months is asymptomatic, is coming for follow-up. His blood pressure was 100/70, heart rate 65. Can you do or add anything in this visit? He is stable now, asymptomatic. Blood pressure is controlled, heart rate is controlled. So you will go for increase the dose of candesartan. You will add an ivabradine. You will add a loop diuretic or add an MRA. Ahmed, رأيك?
Very important question, because we always think that a heart failure patient is always when is asymptomatic, he or she are stable, but this question has a lot of correct and wrong answers, and actually it's very important. Of course, ivabradine is not the option. Ivabradine, yes, the heart rate is okay. And I see the polling is midway between increasing the dose of candesartan and add an MRA. I would love to see what you have for us.
Oh, we can remember that when you use S inhibitor or ARB or beta blocker, you should up titrate up to maximum evidence-based doses. This is a very important. Why? As from the biostate congestive heart failure, it shows that patient with HFrEF who treated with less than 50% of the recommended dose of S inhibitor or ARBs or beta blocker seems to have a greater risk of death and or heart failure hospitalization compared to patients reaching more than 100% of the dose. So the mortality is the lowest when the patient taking 100% or more of the recommended dose from either ACE inhibitor or ARB or beta blocker on other side. So the benefit of mortality from taking the full dose of beta blocker, ACE or ARB. So, okay. So the next step is to up-titrate the Cancer-10. What about the patient? He had diabetic. He now is in climipral 2 milligram, metformin 2000 milligram per day. His fasting blood sugar 150, postprandial 267. What would you do for the control of his diabetic status? Will add TCTs, will add DB4 inhibitor, increase the dose of climipral, add SLG2 inhibitors.
Very important question. And I think this question was very important maybe years ago. I would love to see what the audience will answer here. I just hope nobody says add a thiazolidinediones. I hope this is not anybody chose that. It's 100% SGLT2, Dr. Temer.
100%. Okay. Now, as you mentioned, Ahmed, glycozones are not recommended in patients with heart failure, and they increase the risk of heart failure worsening and heart failure hospitalization. This is class 3 level of evidence. While empagliflozin, SGLT2s, should be considered in patients with type 2 diabetes in order to prevent or delay congestive heart failure and prolong life. According to the guidelines, American guidelines, if we have indicators of high risk or established atherosclerotic cardiovascular disease, chronic kidney disease, or heart failure, our patient have heart failure and established atherosclerotic cardiovascular disease. So consider independently what is the baseline of hemoglobin A1C, what is the target of hemoglobin, he is on metformin or not, and patient have heart failure, particularly if ejection fraction is less than 45, according to American. Ahmed mentions that less than 40. American mentions that less than 45. SGL2 inhibitors with proven benefit in this population is recommended. And the ESC guidelines for management of diabetes and pre-diabetes mentions that if patient had type 2 diabetes and he was a drug-naive patient, assess the risk first. If he is already atherosclerotic cardiovascular disease, if the risk is very high or high, you can start with SGL2 inhibitor or GLP-1 monotherapy. If the patient was in the metformin and the same category of risk, you can add SGL2 inhibitors or GLP-1. So it is wise to add SGL2 inhibitor in this patient for management of diabetes and for prevention and good effects on the heart failure patient. And to summarize our case today, I want to keep the time, it's okay. Heart failure is a serious disease, and we should take each step in diagnosis and treatment very seriously. We should follow the guidelines in the management, as this is the evidence-based for better outcomes for our patients. Up-titration of RAS and beta blockers is extremely important for the mortality benefit they confer. And don't forget the comorbidities. And thank you very much.
Lovely case. I might even just add a thing that SGLT2s don't need up titration.
Yes.
Very important points, Professor Temer. Thank you so much for this case and a lovely day.
انا ما حاولتش اكرر الكلام اللي انت قلته، انا حاولت بس انا حضرتك يعني وضحت بوينت كتير قوي وشرحتها، فانا مريت عليها مرور الكرام بس عشان ما يبقاش فيه دبليكيشن في المعلومه، وتشورتن التايم ونوصل للتارجت بتاعنا ان احنا نكونكلود الكيس هاو تو بروسيد ستيب باي ستيب عشان نوصل للبيست مانجمنت according to the guidelines of competition.
Repetition makes it more accurate. I think everybody second time round got it 100% correct on how to diagnose. Thank you, Professor Temer, for insisting on the physical examination and symptomatology. This is important. The investigations are extremely important. Thank you so much. Just a point, please, everybody, at the end. Thank you all for being with us. push the claim certificate button so you can claim your certificates. And after the 3 waves, you can get an EBAC certificate after that. At the end of the day, we've seen that there are 4 cornerstones for the treatment of heart failure, with the RAS inhibitors, the MRAs, the beta blockers, not all beta blockers, and again, reiterated by Professor Tamer and the first presentation, and SGLT2s, diabetics, non-diabetics, a single dose that do a lot of things for the patient, which are fine. I'd love to thank the moderators. Thank you for the team at ICOM. Thank you so much, and it was been great. Thank you, AstraZeneca, for sponsoring this CME. And guys, look forward next week. There are 2 more important cases of heart failure with reduced ejection fraction and how to manage them. Thank you all, and wishing you a good night. And Professor Tamer, if you'd like to add anything, it would be our pleasure.
Thank you, Ahmed. Thank you for all the moderators. Thank you for Astra. And it was a very interesting day with 2 interesting cases, a lot of practical issues and points, a lot of fruitful discussions of clinical and practical issues. This is very important in our practice to follow these guidelines and to practice our patient in the right way to treat. Thank you, Ahmed, for your managing today and the course. I know you manage all the course. Thank you very much, and thank you for all, and good night for everyone.
Thank you.
Thank you.